Next speaker is Dr. Choi from Seoul in Korea, and she's going to talk about hypertensive anterior uveitis. Thank you.
Thank you, Chairman. I'm Choi from the Catholic University of Korea. It is a great honor for me to speak today. Today, I would like to talk about hypertensive anterior uveitis and current aspect. Among the various kinds of uveitis, glaucoma is most commonly complicated in the cases of anterior uveitis. In uveitic glaucoma, tissues other than optic nerve head and angles are affected, including vitreous, retina, iris, and cornea and epithelium and cornea endothelium, according to its etiology. Glaucoma in uveitis has a nature of episodic and partly iatrogenic nature, and it accompanies very high intraocular pressure. And in 20% of the clinic-based uveitic cases, and it deviates young and of working age and more rapid glaucoma progression than is seen in primary open-angle glaucoma. As you can see in this study using large-scale real-world data, which shows the visual field progression was greater in uveitic glaucoma compared to POH cases. There are many factors influencing intraocular pressure in uveitis, so it is very hard to understand the exact etiology of IOP elevation in these cases. But for the effective treatment, it is very important to understand the mechanism of IOP elevation in these patients. So there is some schematic of recommendation on the etiology of the IOP elevation based on the timing of IOP elevation and inflammation into 4 mechanisms. But in these patients, the aqueous humor outflow is significantly diminished. As you can see in this study, the recurrent anterior uveitis with glaucoma or ocular hypertension showed the lowest outflow facility. Let me show you 2 cases of uveitic glaucoma. First one is a 40-year-old female who had a history of HLA-B27 positive anterior uveitis, and she came to our clinic due to decreased visual acuity. In her slit lamp examination, she showed intensive anterior chamber inflammation. However, her intraocular pressure was 8, relatively low compared to the normal limits. So we started a steroid eye drop, and after the cessation of the inflammation, her IOP goes up into 16. The low IOP in this patient seems to be associated with reduction of aqueous outflow production, as well as profound increase in unconventional drainage. Let me show you another case of 41-year-old male who had visited our clinic for the management of episodic IOP elevation. He had a first attack of uveitis in 1989, and he had recurrences of 1 to 2 times per year. At the time of recurrence, he had been treated by conventional treatments such as steroid and anti-glaucoma eye drop. When he visited our clinic, he showed high intraocular pressure of 30, and he showed some keratic precipitate on his cornea endothelium, but anterior chamber inflammation was very minimal. But he has no glaucomatous damage or no corneal endothelial cell damage at this time. But after that, we had been followed him about 20 years, and he showed the recurrence, increasing recurrence of the attack, and he showed also the decrease in corneal endothelial cell count. So in 2022, we performed the aqueous humor analysis, PCR analysis, and he showed cytomegalovirus positive results. After the initiation of antiviral agent, his recurrence has been diminished. However, at the last examination, he showed about the half of corneal endothelial cell count compared to the baseline examination. In this case, the IOP elevation is related to trabeculitis, and in these days, it is supposed that the major cause of this kind of IOP elevation is related to infection, particularly virus infections such as HSV1 and cytomegalovirus and toxoplasmosis et al. Some working group had summarized the key findings of this viral anterior uveitis. This is HSV1 uveitis and varicella zoster, and finally cytomegalovirus. Although they did not specify any representative clinical finding, it is known that the coin-shaped lesion, as you can see here, it is the key finding of CMV anterior uveitis. When I summarize the key findings of Sun working group reports, the prevalence of high intraocular pressure, ocular hypertension was seen in the cytomegalovirus in 50% of the cases, followed by HSV1 and varicella zoster and sarcoidosis. It is not surprising that infection causes 50% of the uveitis cases, and it is related to the fact that anterior chamber has a immune privilege, such like the testis or CNS. In this IOP elevation, the direct inflammation of the trabecular meshwork cells is very important because it has a key role in regulation of intraocular pressure. Our group had infected these viruses in the human trabecular meshwork cell, and we could find that the cytomegalovirus is very permissive in TM cells compared to the control cells, as well. And in addition, HSV1 was also very permissive. And we could find that the virus induced contraction of the trabecular meshwork cells, including the cytoskeletal changes, which collectively increased the intraocular pressure. I had the opportunity to have a visiting scholarship in Duke Eye Center, working in Dr. Basanta Rao's lab, and we studied the proteomic analysis of aqueous humor derived from cytomegalovirus-associated hypertensive anterior uveitis, and we could find that 50 proteins were significantly elevated. And we could find that the top significant overrepresented pathway includes complement activation and humoral immune response. We could summarize the proposed IOP elevation mechanism in virus-induced hypertensive anterior uveitis. First is the host immunity, and the second is virus-induced direct changes. And we could study the two more factors. First one is the role of TGF-beta in these cases. In Singapore group, they reported that in post-Schlossman syndrome had a significantly elevated TGF-beta 2 level compared to the cataract controls. Actually, TGF-beta is very important in the pathogenesis of glaucoma. TGF-beta 2 has been known to be elevated in primary open-angle glaucoma and TGF-beta 1 in pseudoexfoliation glaucoma. And also it is elevated in patients with failure of glaucoma filtration surgery. We performed the engineered pathway analysis in the same sample, and we could find that the top upstream regulator in aqueous humor of CMV anterior uveitis was TGF-beta 1. When we infect the cytomegalovirus in human trabecular meshwork cells, we could find that increased level of TGF-beta 1 in cytomegalovirus-infected trabecular meshwork cells. So we performed the analysis of concentration of aqueous cytokines in these patients. This is the demographics. And we could find that a higher concentration in the aqueous TGF-beta 1 level in hypertensive anterior uveitis compared to the controls. And also in the patients with hypertensive anterior uveitis, those with glaucoma surgery had a higher level of TGF-beta 1. Which shows TGF-beta is elevated and have a role in these patients. Finally, I would like to focus on the role of chemoattractant cytokines. Extensive literature has been suggested that these cytokines has been elevated in post-Schlossman syndrome and uveitic glaucoma. When we infect the HSV1 in trabecular meshwork cells, we could find that these chemokines had been elevated in the cells, recruiting neutrophil and macrophage respectively. When we applied these cytokines into the trabecular meshwork cells, we could find the significant increase in myosin light chain phosphorylation, which induces cytoskeletal contraction of the TM cells and finally increasing intraocular pressure. Let me summarize. The virus infection is the predominant cause of hypertensive anterior uveitis. Among these virus infection, cytomegalovirus is the major cause of intractable cases of hypertensive anterior uveitis, which is characterized by a recurrent episode of elevated intraocular pressure and progressive loss of cornea endotheliums. Active viral infection in the TM cells could be the key mechanism underlying the IOP elevation in these cases. Other causes include TGF-beta signaling, increased chemokine, and also host immunity could play a role in the IOP elevation in these cases. Thank you for your attention.
Thank you so much, ma'am. It's an excellent presentation. Any questions from the floor, please? Thank you. We will take it up.